Hello, my name is Jane Davies. I'm a consultant paediatrician specialising in cystic fibrosis at the Royal Brompton Hospital in London and Imperial College. Thank you very much to the organisers of this conference for inviting me to give a keynote lecture this year. Those drugs which are currently in the clinic, as you will be very aware, are produced by Vertex. I'll be talking a lot about those drugs themselves, but also referencing some other drugs from companies which are still in clinical trials with whom I've worked either on those trials or in advisory boards. I'll talk a little first about how we got to the exciting place we're in today, before talking about the benefits of the highly effective triple combination known as CAF Trio in Europe and Trikafta in America. And then I'll talk a little bit at the end about the challenges that still face us as a community in cystic fibrosis and where I think we should move into the future. So if we cast our minds back just over 30 years, we had a real step change in our understanding of cystic fibrosis. This was 1989 and the year that the cystic fibrosis gene was first described and published by Francis Collins, Lapchi Choi and colleagues. And this really led to a complete shift in what we understand about cystic fibrosis today. So the protein that is produced by the cystic fibrosis gene sits on the surface of lots of cells within the body. You can see one of them here illustrated in this cartoon. And its main function is that it acts as a gate for salts leaving the cells. You can see here chloride salts going out through the open CFTR channels. We know that other salts can also pass through there, and that the CFTR can talk to its neighbouring channels and influence the passage of sodium ions, for example. This is very complicated cell biology and probably not necessary for us to go into it today, but if you could keep in your minds that for this protein to function properly, it needs to sit at the surface of cells and it needs to be able to open and close and allow salts out of the cell. People with cystic fibrosis have gene mutations which mean that this process fails somehow. There are a number of different ways in which this can happen, and the biology of this is also very complicated. I've broken it down to make it easier to digest here. On the left-hand side of this slide, you can see a cut through a cell. The nucleus, where all of the genetic material of the cell is stored, is down at the bottom in brown. And anything that's made from the genes inside the nucleus passes up through the cell as a protein, and in the case of CFTR, requires to sit on the cell surface and function. So people with cystic fibrosis can have a number of different gene changes that lead to problems with this protein. The first of these is simply that no protein is made. Many of these mutations end with the X, for example G542X that some of you may have heard about, but not all do in this class. And this is about 10% of people worldwide with these mutations. The next type of mutation leads to a protein that gets stuck in the wrong place in the cell. And this is important because it is the most common, by far, mutation in this class. So this protein gets made, but it doesn't get to the place where it needs to function. Then there are other types of mutations which can lead to a protein which does get to the cell surface, which either doesn't work properly or just isn't there in sufficient amount for normal function. Now, breaking these mechanisms down have allowed us to think about the way we develop drugs, and quite easily modulated drugs can fall into three different groups based on these gene changes. So if we think about the first group where there's no protein made, the concept of modulators that we think about at the moment is that they're drugs that work on the CFTR protein. So for this class of mutations, these will be unresponsive to the current modulators and will need alternative approaches, for example, gene or mRNA-based therapies. The types of protein that get stuck in the wrong place can be helped to the cell surface by a group of drugs which we're commonly calling correctors. And then this group here, where there is protein at the cell surface which doesn't work properly or isn't there in sufficient number, can be helped to work better by groups of drugs which we call potentiators. And it was this type of approach which was the first across the finish line through clinical trials into licensed medicines. And I'll talk to you a little about that first, because I think what we've learned from these drugs really sets the scene for our expectations for some of the triple molecules, Kaftrio being the first of those. So I think you'll all be very familiar now with ivacaftor. This is a potentiator, it's taken by mouth, and it was the first drug produced by any company, this was Vertex, through clinical trials into the clinic. You can see here the phase 3 trial. So phase 3 is the stage of trial before a company will normally go and request a license. And you can see here massive changes in sweat chloride, a very useful biomarker of any drug that's taken by mouth. A big improvement in lung function, measured here by FEV1, of around 10%. A reduced frequency of pulmonary exacerbations on the bottom left by about 1/3 to 1/2, and also very encouraging improvements in weight gain. So this was a trial that lasted a 1-year period. I think most people would understand that what really matters to patients, and therefore also to the clinical community, is the longer term outcomes. And the head start that we got with ivacaftor means that we now have around 5 years of data from people taking this drug so that we can look at these longer term implications. I'm going to talk to you about this one paper, which was a collaborative effort between the patient registries of the US and the UK, and looked at 5 years of data comparing people with the mutations suitable for that drug with patients who had different mutations who weren't suitable for the drug. They tried to match the patients as much as possible at the start of the study, and they looked at a number of long-term outcomes. The first of these is exacerbations. You will all be very aware of how much of an impact these have on patients' lives, not only the inconvenience of being admitted to hospital, missing school and work, but also the consequent decrease in lung function that will happen after a proportion of these. All of these slides are similar, with the US data on the left and the UK data on the right. In black is the comparator group, so patients not receiving ivacaftor, and in grey bars is the other patients receiving ivacaftor. Firstly, the baseline year before that became available, and then subsequent years thereafter. If we look first of all to the US data, we'll see in the baseline year, people who had mutations suitable for ivacaftor had slightly more pulmonary exacerbations than the comparator group, but this fell after the first year and fell further in the second year, that gap therefore widening as the groups progressed. And we see a very, very similar impact over a 4-year period in the UK. Here we have Pseudomonas aeruginosa infection. Many of you will be aware this is the commonest infection chronically affecting people with cystic fibrosis. It reduces lung function, increases the frequency of exacerbations. And we can see a very similar impact. Shortly after commencing ivacaftor, the group in grey have substantially fewer infections with this organism, both in the US registry and in the UK. And then obviously one of the things which really worries people with cystic fibrosis is the way the disease is very cruel and causes patients to lose lung function over time. Both data sets on patients receiving ivacaftor in the long term were very, very encouraging in this regard. So patients experience an immediate, acute improvement in lung function, but also a slowing in the rate at which that lung function was lost over time. And that had consequences in terms of significant improvements in survival and a reduced requirement for lung transplantation. So very major long-term consequences of ivacaftor, which sounds absolutely fantastic until we remember that the group of patients who are suitable to receive ivacaftor on their own and experience this benefit is only about 5 or 6% of the worldwide population. Most patients are not suitable for this drug as a monotherapy. This is suitable only for people who have that protein sitting at the cell surface which needs additional help to make it function properly. We can see here how relatively uncommon that group is. If you look towards the top right of this pie chart into the white section, G551D is by far the commonest of those gating mutations in patients who are suitable for ivacaftor. This is the 25 most common CFTR mutations in people with cystic fibrosis in 2018 from US data. These data do differ in different populations, but not very much when we think about the massive dominance of this one mutation shown here in the yellow, which is F508del, present on almost 85% of chromosomes, so the genes, in patients who have cystic fibrosis. That clearly is the gene mutation that we need to focus on if we're going to make a big difference to large numbers of people with cystic fibrosis. And of course, that is where attention turned. As I said earlier, the problem with the F508del is that it doesn't reach the cell surface. Now, the reason for this is that it's misfolded. So when it is being produced within the cell, it doesn't fold into the correct shape, and the cell recognizes it as being wonky or abnormal, and it degrades it in the intracellular dustbin processes. Correctors are drugs which can correct that folding and allow the protein to make it up to the cell surface. Correctors were developed by Vertex. Lumacaftor was the first of these, and it became fairly clear that although they were able to take some protein up to the cell surface, they weren't sufficiently good at doing it that they could work well clinically on their own. And so the notion of combinations with a corrector and a potentiator was born. And as you will know, we have seen some success with these now. Here is the results from two large trials, Traffic and Transport, which looked at patients with 2 copies of F508del, giving them the combination of lumacaftor as a corrector and ivacaftor as a potentiator. Their lung function improvement is seen here in blue, compared with a placebo group who didn't get active drug. And you can see significant improvements over the first few months of this drug. The placebo group later rolled over to get access through the drug in a further trial, and they also improved. But these improvements were around 3% compared to the improvements we'd seen in the ivacaftor trial, which was more like 10%. There were also some patients experiencing side effects with this particular combination. Here we see a rather more dramatic improvement in pulmonary exacerbations. So either those events leading to admission to hospital on the left, or those leading to intravenous antibiotic treatment, which could sometimes have been at home on the right. There was then a second corrector produced by Vertex, tezacaftor, and this is now marketed in combination with ivacaftor as Symkevi. Better tolerated, but very similar improvements, so more like 3 or 4% than the 10% that we had been led to hope for from ivacaftor. So it was really the fact that we were seeing somewhat more modest improvements in benefits with the dual correctors that led to this leap for a search to a more effective drug, and the concept of triple combinations was born. I'll talk a little about why triple combinations are needed first of all. And this is just a picture of the CFTR protein, which I think helps those of us who aren't protein scientists to understand just how complicated this structure is, and how also complicated some of the folding problems in F508 are. So the reason why we need more than one corrector is probably because there are more than one misfolding problems in the F508del. The way in which I've tried to explain this to people is that we may need different tools for performing different tasks. So here is a tangle of a ball of wool. We might quite easily be able to put that into something that looks more like a ball of wool, but if we actually want to knit that into a scarf, we'll need a different set of tools to do that. And that really is the concept of the triple molecules. They have two correctors in them which have different mechanisms addressing different parts of the misfolding problem, and then a boost to the function of the protein with the potentiator ivacaftor. I'm going to show you now the really exciting trial data that were published in autumn of 2019. Two groups of patients here, and I'm going to show you first of all the first of those groups. If you look at the left of this slide, you will see a code which says F-MF. So these are patients who have one copy of F508del. Their other mutation is a mutation which does not respond to any of these drugs and which doesn't lead to any partial function of CFTR protein. The MF stands for minimal function. All I want you to take away from this is patients who just have a single copy of F508del, and also that all three of these drugs will only be working on that single copy. They won't work on the other. And really excitingly, and for the first time, we see very, very substantial improvements in lung function in this group of patients. Within the first 2 weeks of starting the drug, compared to the placebo, a 13% improvement in FEV1. There was also a very significant reduction in the numbers of people having pulmonary exacerbations. So you can see here all exacerbations in the first bars reduced by 2/3, and then a reduction also in patients needing hospitalizing or intravenous antibiotics. This is the first time that any CFTR modulator drug has been so effective that it's been able to be used in patients with only one copy of F508del. There was a trial running at around the same time in patients homozygous for F508del, so that means 2 copies. And remember, this is the vast majority of people with cystic fibrosis, so around half of people in the world have 2 copies of F508del. The Symkevi drug, tezacaftor, ivacaftor, was already available for these patients, so this trial had to be designed a little bit differently. It's obviously not ethical to put people on placebo and deny them the benefit they may be getting from a previous drug. So this was a shorter trial over a period of 4 weeks, which compared people stable on Symkevi with the introduction of the single new corrector, elexacaftor. And you can see here a similar impressive improvement in FEV1 of around 10% points on top of the 4% that people would have been gaining from their Symkevi. This is what we call a waterfall plot, and this looks at individual responses within patients. So within any clinical trial, there will be people who respond really dramatically and people who have less of a dramatic response. We recognise that in clinical medicine, and it's also the case in most trials. And these graphs are a very useful way for us to try and look at the variability in response to a new drug. So in grey here, you can see the placebo group. The highest of those bars is the group of patients who had no change or a slight drop in their lung function over the 6 months of that study. But you can see there is a little spread, including a small number of patients who had improvements. What you can see is that the responses to the triple therapy in blue are in general much higher, and all of them to the right side of the 0 mark, apart from a very, very small number that you can see here. Some patients experiencing improvements of more than 25 or 30 percentage points in their FEV1. I'm going to come on now to some of the other outcome measures of that trial. First of all, on the top again, patients who've just got a single 508del, and first of these graphs on the left is the sweat chloride concentration. similar to what we saw with ivacaftor, very substantial decreases in this useful biomarker, and very similar to what we've seen previously with the drugs that gave the 5-year prolonged benefit. In the middle there is something we call the CFQR. This is a quality of life measure, and we know a lot about this quality of life measure. We know that the minimal important difference that patients report can be as low as 4 units, which is shown here in the blue dotted line. And patients who were on the triple therapy reported somewhere in the region of 16 or 17 percentage points in terms of their quality of life. On the right is body mass index, and you can see similar improvements as to what was seen with ivacaftor in the chart that I showed you previously. Not all of these outcome measures were measured in the shorter study of homozygous patients, but you can see very similar dramatic decreases in sweat chloride and similar improvements in quality of life scores. These trials were published back-to-back in 2 very high-profile medical journals, which you can see here should you be interested to go and look in more detail at them. And one important aspect that you will see if you look at these is that these drugs had a good safety profile. We know that all of the CFTR modulator drugs can lead to some disturbance in liver function in some patients, and that is the reason why we're monitoring this on blood tests relatively frequently when the drugs are started, and then at longer periods later. But other side effects were very, very minimal, and in general these drugs are safe and well tolerated. So this has made a very big difference to the modulator landscape as we see it now. What we have here is the different types of mutations that the populations and the proportions of the populations experience. So first of all, we had ivacaftor approved for patients with gating mutations and some mutations that we call residual function. We then had these dual molecules approved largely for patients with 2 copies of F508del, although Symkevi has also been approved for some patients with residual function. And then along came the triple combination here, which was approved by the FDA in America in October 2019. And we had the very welcome news in the summer of 2020 that the European Medicines Agency had also approved this drug. You may wonder why some of these are in yellow. The reason is that I think many people would regard ivacaftor as a drug on its own and the triple molecules as being substantially more effective than those dual molecules I talked to you about earlier, and you may sometimes hear them referred to as highly effective modulators or HEM. I'm a pediatrician, so of course this question comes into my mind a lot, and many of you may be parents of children with cystic fibrosis. Most of the trial data that I've shown you at the moment, and certainly all of that for the triple molecules, has come from patients who were 12 years old and above, so adolescents and adults. Can we achieve more if we start this earlier in the life of somebody with cystic fibrosis? And my answer is almost certainly we can with lung disease. We know that it may be easier to prevent or delay lung disease than reverse it once it's present, and certainly severe lung disease and bronchiectasis is largely thought to be irreversible. I was very pleased to see some press release data from a trial in 6 to 11-year-olds saying there was a good safety and efficacy outcome from this age group with triple therapy very recently. Here is a link to that should you wish to look at it. I must emphasize that this data has not yet been reviewed in a peer process fashion as it would be before it's published as a manuscript, but we eagerly await that data coming out in the manuscript. I think one of the very exciting questions though about starting these drugs early is whether we can impact disease outside the lungs as well. And for the first time we have some, I think, very exciting evidence that it might be possible to have an impact on the pancreas. So here are some trial data. This looks very busy, I know, in patients who were between the ages of 2 and 5 years who had a gating mutation that was suitable for ivacaftor. And these are data from the first 24 weeks in a study called Kiwi, and then much longer periods as those kids were allowed to continue taking drug in a longer extension phase called Climb. The marker you can see here is fecal elastase, which is the best measure in the stool of pancreatic function. The dotted line there at the 200 mark is usually the distinction we make when we're trying to decide whether a child needs to go onto pancreatic enzymes such as Creon. So a small proportion of children will not need enzymes, and you can see in fact there is one child here who came into the trial with very good pancreatic function, and that was because in addition to his gating mutation he had a residual function mutation. He had a slightly milder disease course. All of the other kids here have very low levels of fecal elastase. They were pancreatic insufficient and they were being treated with pancreatic enzymes. Within the first 24 weeks, you can see that a proportion of those children restore the levels of that biomarker into the range, which would mean we may consider whether they still need to be taking pancreatic enzymes. Follow-up period, there was some wobble in this, but many of those children remained above that cutoff, and there are now several publications in the literature of children starting ivacaftor and being able to stop taking their pancreatic enzyme supplements. It's important when we think about the pancreas not just to think about enzymes, but also to think about the other aspect of pancreatic disease, which is CF-related diabetes. Now, this is a common complication, becoming more commoner in teenage life and adults, and these are those data from the registry comparison again, where you can see that ivacaftor over a 5 or 4 year period did appear to decrease the proportion of people who were diagnosed with CF-related diabetes. Now, this is a very, very important outcome that we need to be following carefully, but I might predict that the earlier we start a highly effective modulator treatment, the more impact we'll have on outcomes such as these in the longer term. I think it's really important that we do capture the full potential for benefit of these drugs and not just rely on the small number of measures that are put into clinical trials. So I'm very pleased that the Cystic Fibrosis Foundation are running a study called PROMISE, which is evaluating a huge number of outcomes of patients who are starting on Kaftrio. There's also a study called RECOVER, which I'm proud to say is just starting in Ireland and in the UK, which is a similar design funded by Cystic Fibrosis Foundation and the Cystic Fibrosis Trust in the UK and CF Ireland. And I hope that we will have some complementary data. The outcome measures are not identical. We're going to have more outcome measures related to lung function in terms of CT scans and more advanced sensitive lung function measurements. So it's very nice to be working collaboratively on that project. So this is fantastic, and I hope you're all feeling really encouraged by the progress we've made. But I'd like to look forward now and say, is that it? Is our job done? And I very much think that it is not yet. We do have more work to do. As you will recall from one of my earlier slides, there is a proportion of people who have mutations that are not responsive to these drugs. There are patients who have established disease which we may not be able to turn the clock back on, and people are still getting pulmonary exacerbations. They've been reduced, not completely prevented. People who have chronic infection, very well established, may not get that cleared by some of these drugs. So for all these reasons, we do need to continue to pursue new treatments, both more CFTR-directed approaches and also those tackling inflammation, infection, etc. Some patients don't tolerate these drugs. Now, fortunately, that does seem to be a minority, but there may be other CFTR modulators that are needed to help that particular group. And then this is a really big issue, is that there are clearly regional differences in availability of these drugs. They are extremely high cost, and there are regions of the world for whom these drugs will be unaffordable. It's essential that we continue to support these attempts to widen the spectrum of drugs that are available. So here's a snapshot from the Cystic Fibrosis Foundation Therapeutic Development Network drug pipeline, where in real time there is an update on which types of drugs are coming through clinical trials and getting through to patients. And you can see here at the phase 2, so that is the more experimental, proving some efficacy phase, there's a large number of different modulators being trialed, actually focused on CFTR function. I'd also like to show you, though, there's a huge number more at the preclinical stage, and this includes quite a number of different approaches which might suit people who don't have modulator responsible mutations. So those, for example, based on gene therapy or read-through agents which may help people with the class 1 or stop mutations. So I think this is very encouraging, and it's essential that our trials networks continues to support the development of these drugs so that we can assess whether or not they're efficacious and safe. Finally, I just want to talk about a group of patients with very rare mutations that we may not even understand fully. And there are a number of exciting approaches being adopted to try and help those patients and understand whether drugs that we have available might be suitable for them. And there's a number of different cell-based ways in which we can do that, but I'd like to focus particularly on the right-hand side of this slide, the so-called field of theranostics. And what this means is taking cells out of a patient, growing them in the laboratory, and then subjecting them to different types of experimental drugs to see whether or not we see an impact on the basis of their combination of gene mutations. One of the most exciting of these is on the bottom right here, which is taking intestinal cells, growing them into little spherical bodies, and having a look at how they swell in response to challenges with different drugs. So I think that this is a very exciting time. I hope you agree with me that we're getting closer and closer to the shared vision of best drugs to all patients as quickly as possible. But undoubtedly we do still have some work to do. I'm very, very pleased that globally networks are coming together to face this challenge, both in the US and in Europe, and that we're increasingly working with our patient organisations, both nationally and internationally. It's been my pleasure to provide you with this update today. If you would like to get in touch with any queries or join the session that we may have later on during the conference, please do so. Here are my contact details. It's been a great pleasure talking to you, and I hope you enjoy the rest of the conference.